My name is Christopher Pham from the Keck School of Medicine of USC. I'm currently in internal medicine in the LAC USC Medical Center, and I will be presenting a case on gestational transient thyrotoxicosis in a pregnant patient with previous Graves' disease, working with Dr. Caroline Nguyen, attending of Division of Endocrinology and Metabolism, as well as the Department of Obstetrics and Gynecology. Going into the background, there are two causes of hyperthyroidism in pregnancy, which can include Graves' disease and gestational transient thyrotoxicosis. It can be difficult to differentiate the etiology of the case of the two sources of the hyperthyroidism, but it is crucial in pregnant patients because the former requires treatment with antithyroid drugs in Graves' disease, while in gestational transient thyrotoxicosis does not require treatment and is treated with supportive care. So for the HPI, a 29-year-old female, gravidum 4, para 2, with one history of miscarriage as well as 2 living children, presents with 1 week of vomiting, diarrhea, and chest pressure at 9 weeks gestation. She reports a new diagnosis of Graves' disease and was previously on ADT 4 months ago. However, self-discontinued 1 month previously due to her missed period. When she was seen in the emergency room, her vitals were pertinent for normothermia, as well as sinus tachycardia of 104. She was hemodynamically stable with a BP of 106/62, and was not tachypnic and was saturating well in room air. In terms of her mental status, she reports she was alert-oriented to person, place, and time, and her physical exam was also negative for any source of Graves' eye disease. In terms of her thyroid exam, she had a palpable goiter that was enlarged, 2+ in size, which was homogeneous, non-tender, without nodules or lymphadenopathy. Labs were drawn in the emergency room with a significant for overt hyperthyroidism with a TSH of less than 0.01, a free T4 of 1.75, a total T4 of 16, and a free T3 of 5.5. However, TRAB and TSI were still pending. Of note, when she was initially diagnosed with Graves' disease 4 months ago, her TRAB was noted to be positive at time of diagnosis. So the decision was made given her previous history of Graves' disease, as well as overt hyperthyroidism, as well as goiter, to initiate purple thyrouracil treatment. And she was seen in clinic in 1 week afterwards. At that time, the TRAB and TSI resulted as normal, and thus the decision was made for PTU to be discontinued. Her TSH was normalized at 19 weeks gestation, and thyroxine levels remained normal off PTU. The patient ultimately underwent elective C-section at 39 weeks gestation without any fetal or maternal complications. And over here is the figure where you can see the trend of the TSH, the free T4, and the TRAB as well. So gestational transient thyrotoxicosis affects 1 to 3% of all pregnancies, and is a condition associated with elevated free T4, free T3, as well as elevated HCG with a normal TRAB, and is more common than Graves' disease, which has a prevalence of about 0.4 to 1%. Gestational transient thyrotoxicosis is associated with hyperemesis gravidarum and is potentially more prevalent in patients with Graves' disease who were previously treated, regardless of therapy. Graves' disease requires treatment with antithyroid drugs that can have potential teratogenicity and as well as cause fetal hypothyroidism, while gestational transient thyrotoxicosis is self-limiting and not associated with poor outcomes in the fetus or mother. The TRAB and the TSI can be critical in determining etiology of hyperthyroidism, as such in this case in a patient with physical exam findings consistent with Graves' disease, however with a negative TRAB. A history of Graves' disease does not exclude gestational transient thyrotoxicosis, and determining the etiology of hyperthyroidism is essential in preventing unnecessary treatment with antithyroid drugs. And finally, in patients presenting with hyperthyroidism in pregnancy, a TRAB and TSI should be checked to help differentiate between Graves' disease and gestational transient thyrotoxicosis.